Welcome to all, and thank you for making the time to join our webinar today on empowering caregivers with strategies to support children with symptoms of avoidant restrictive food intake disorder, or ARFID, presented by Dr. Caitlin Borner and Dr. Jennifer Coelho. My name is Nisha Parker, and I'm a project manager at BC Children's Kelty Mental Health Resource Center. Before we begin, I'd like to start by respectfully and gratefully acknowledging that the Kelty Mental Health Resource Center is located on the unceded traditional and ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations. Before we start our presentation, I'd like to take a moment to share with you a little bit about the Kelty Center and the services that we offer. We are a provincial mental health and substance use resource center for parents and caregivers of children and youth up to age 24. We help families across the province by helping them to navigate the mental health system. We offer peer support from family peer support workers, and we also connect families to free resources and tools, including our Where You Are podcast, webinars, and more, all of which you can find on our website, keltymentalhealth.ca. And my colleague, Catherine, will put this in the chat, and we'll also be adding links in the chat throughout the webinar. A few housekeeping notes as well. Attendees are automatically muted and cameras are turned off. For questions today, we will have a dedicated Q&A session after the main presentation. We have asked you to submit questions ahead of time, so we will be reading those questions. If we have time, there will also be an opportunity to ask questions during the webinar. Please submit questions for the speakers through the Q&A function. If you are experiencing any technical issues, for example, issues with sound, please submit these through the chat function, and my colleague in the background will support you with that. At the end of the webinar, a feedback survey will pop up that we invite you to complete. This really helps us to improve future webinars at the Kelty Center, so we really appreciate if you can fill it out. This webinar is being recorded, and it will be made available on our website at keltymentalhealth.ca/events, and all webinar registrants will also receive an email with the link to the recording once it's available. Please note that the information in today's webinar applies to the context of British Columbia. If you are in another jurisdiction, please consult your local health authorities for further information that might be more specific to you. And finally, if you are a parent or caregiver of a child aged 4 years or older with symptoms related to ARFID, you are invited to participate in a short online study. We have invited people to participate in the study before watching the webinar, but if you haven't had a chance yet, it's also okay to participate shortly after watching the webinar. So if you would like to learn more about this study, or if you're interested in participating, the link is in the chat. And now to introduce our speakers. Dr. Caitlin Borner is an assistant professor in the Division of Developmental Pediatrics at the University of British Columbia. She's an investigator at BC Children's Hospital Research Institute and provides care as a registered psychologist with the Complex Pain Service at BC Children's Hospital. Dr. Borner has an interest in how eating is impacted by abdominal pain and gastrointestinal conditions. Dr. Jennifer Coelho is a clinical associate professor in the Department of Psychiatry at the University of British Columbia. She is an investigator at BC Children's Hospital Research Institute and provides care as a registered psychologist with the Provincial Specialized Eating Disorders Program at BC Children's Hospital. Dr. Coelho's research focuses on strategies to improve care for youth, their families, and the clinicians who provide care for eating disorders. Thank you so much for being here, Dr. Borner and Dr. Coelho, and over to you.
Thanks so much, Nisha, for the introduction, and to all of you present today at this webinar. We're so grateful for the strong interest that we've had in the topic that we'll be speaking to today. Before we start, we just want to highlight some disclosures that both Dr. Berner and I bring to the work that we do. And so I wanted to highlight that I receive research funding from a variety of agencies. These are nonprofit and government agencies that help provide support for understanding how research can inform clinical care. And similarly, Dr. Berner receives some research funding and support and also has a small private practice. Now, to set the stage before we get into the webinar this morning, we want to highlight that something you'll hear about is that ARFID can look a lot of different ways. And in this short time that we have for the webinar today, we can't go into detail about every scenario, every situation. So there may be some things specific to your situation or your family that we won't touch on today. We will be focusing on understanding more about what is ARFID, and strategies that caregivers can use that are helpful for different types of ARFID symptoms. We really encourage you to think about speaking to your primary care provider about options for supports specific to your family if there are questions that come up after the webinar today. And as Nisha indicated, there's a Q&A option, and so we'll have the opportunity for general questions at the end, but want to highlight that we won't be able to answer questions about how to address specific clinical situations that you and your family may be experiencing. Now, to start off, I really want to ground ourselves in some of the truths that are applicable across all types of eating disorders. And these have been published by the Academy for Eating Disorders. They're available in multiple languages, and the link to access these will be in the chat. And a couple that I really want to highlight as we start into this topic of thinking about ARFID are that families are not to blame. So looking at truth number 2, in fact, families and caregivers can really be the best allies in treatment. You're the ones who, as caregivers, really know what works best for your child, some of the things that you may have tried that haven't been a good click. And so this is what we're really focusing on today, is how caregivers can be there as a support. And then the second part, looking to truth number 4, that eating disorders aren't choices, but are really serious biologically influenced illnesses. And we often hear from families as they launch into clinical care, reflecting on what might have caused their child's eating disorder or ARFID symptoms. And what we really want to highlight is we don't necessarily need to know exactly what caused it in order to have effective treatment. And we'll be touching on this throughout the webinar today with our learning goals, understanding what eating patterns might fit with symptoms of ARFID or avoidant restrictive food intake disorder, helping ideas for making changes to eating routines that may be happening in your family's household. And then finally, touching on understanding how to support your child if their eating is connected to another concern, such as pain or discomfort. And so as we launch in, I want to share a story. This is a story of a mix of different cases of families who we've supported over the years to help us think about when might we need to think about specific supports? When does this go beyond what might be expected of child development and picky eating? And so I'm going to share Adrian's story. Adrian is a 14-year-old, and imagine a meeting with the parents for a first assessment, meeting together. And parents share that Adrian has always been a picky eater. They share that Adrian eats about 10 to 12 foods, and a lot of these foods tend to be brown foods. So that might be breakfast cereals, Oreo cookies, Coca-Cola, French fries, and spaghetti without sauce. Adrian's parents share that they've gone for regular medical monitoring and there aren't concerns about growth and development, no concerns about being underweight, no concerns that have been identified about dietary insufficiency. So things are on track from a medical stability perspective. But parents share that it's been really hard to accommodate their child's limited eating preferences, especially when they're traveling. They might not be able to purchase the same brands of foods while away from home, and this can lead to a lot of distress, both within Adrian and then the family trying to figure out what can we do to help support continued eating while we're away. And lately, Adrian's been refusing to go to some social events like summer camps with friends and sharing that it's really due to worries about the food that will be provided during those times. Adrian avoids sleepovers, avoids parties with friends, because they really don't feel comfortable eating at other people's houses. But Adrian also feels like they're missing out. They're not avoiding this because they're worried about seeing their friends. They're avoiding this because of the food situation. And so, as we're thinking about Adrian's story, part of what we want to highlight is understanding, when does this go to a point where it might be helpful to seek out supports and clinical care for your child? And in terms of how we define ARFID, or what the diagnostic criteria are to say that this fits with a pattern of ARFID, children may be living with ARFID if they're not eating enough, and we see a few different areas. So either they're not growing as expected due to the restriction, or maybe they're losing weight. They might be experiencing nutritional deficiency. Maybe they're needing to have tube feeds or having a hard time having oral eating and drinking oral supplement drinks or meal replacement drinks instead of having solid foods. And then kind of overlapping with Adrian's case, we can see that if a child isn't eating enough and they're having a hard time socially in a way that really gets in the way of day-to-day life because of their eating, that can also be considered to be a symptom of ARFID. So I'll hand over to Caitlin now.
Thanks, Jennifer. So this wasn't raised in Adrian's case, but is true for a lot of young people who are struggling with eating, that they might have another diagnosis or condition that they're managing at the same time. And this can make it really hard for families to know, what's going on here. Is this ARFID that is, over and above what's happening with their other condition? And some important questions to ask are, is their eating problem more severe than what's expected for that condition or diagnosis? So for example, if you have an eating restriction that's been recommended by a doctor, say because of a food allergy or a condition like celiac disease, does the eating problem extend beyond what's been recommended by their health professional? And does your child need medical help for their eating problem that is sort of separate from their other diagnosis or condition? Now that we've reviewed some of the features of ARFID, this link here might provide a starting place for families to understand if your child's symptoms might need a closer look. So this ARFID screener is something that you can use just to get a sense of, is this something that I should be raising with my primary care provider? Are there maybe some more supports that are needed for my child or for my family? We wanted to raise that, often when families are dealing with ARFID or ARFID symptoms, they've often tried a variety of strategies. And a really common one that's recommended to families is called the division of responsibility. And this is where parents set the expectation of what, when, and where meals will be served. But then the child decides whether to eat and how much to eat. And this is advice that might work really well for children who don't have disordered eating or who don't have symptoms of ARFID. But often this advice can be really challenging for families who are dealing with ARFID symptoms to implement, because it may be the case that the parent is deciding what, when, and where meals will be served, and the child is deciding that eating is not something that they're comfortable doing. So these types of recommendations might not be helpful for children and young people with ARFID.
Now, a few years ago, there was a project run across Canada where pediatricians were invited to respond to a survey to understand who was presenting across Canada with symptoms and diagnoses with ARFID, in order to understand more about what are families experiencing across Canada in terms of some of the ARFID diagnosis. And this was part of a Canadian pediatric surveillance project, so understanding more about how many individuals across Canada are presenting. And what the study showed is that children between the ages of 10 to 14 were the most likely, out of all of the age groups of the respondents, to grow more slowly than expected during a time that's usually an adolescent growth spurt. And so sometimes it may be that a child has been having restrictive eating, and as they come up to adolescence and puberty, and they would normally experience a growth spurt, the restriction gets in the way of being able to experience that and can lead to medical instability. In fact, in that surveillance study, they showed that about 40% of the children for whom the pediatricians were responding needed hospitalization for their eating concerns. And so this is really to highlight ARFID is more than just picky eating, and it is something that does require intervention. And we can see some serious medical consequences of the food restriction that really needs supports in order to help children and youth get back on their growth trajectory and be able to live medically stable. Now, sometimes we hear from families about not being sure what type of eating disorder is leading to restriction in their child and wondering, could this be another type of eating disorder, or not sure how to approach a care provider and what to share. And this can be tricky because we know that there are other eating disorders like anorexia nervosa, where somebody might restrict, and the reasons for that look really different. It might be that in anorexia nervosa, somebody is restricting because they're trying purposefully to control their weight and shape, and that weight and shape forms a really important part of how they feel as a person and how they evaluate themselves. But it can be tricky with some younger children in particular, because somebody might say that they're not really worried about gaining weight and still not be eating enough to gain weight, and not really have insight into that low weight being a really serious concern. So have a hard time understanding why families and doctors might be worried about them. And sometimes children may also not have the language to talk about body image distress. So something that caregivers can do as they're trying to understand, is this restriction linked to body image concerns, or could it be something else? To be watching for what kinds of behaviors is your child engaging in. Sometimes families describe not hearing about body image concerns, but then seeing their child look in the mirror really often, or look at reflective surfaces, or measuring parts of their body, or having other types of ways of assessing their body and whether they're losing weight or how they might feel about their body. And another thing that families sometimes describe is the types of food a child wants to eat or is restricting. And we'll be talking more about the certain types of ARFID behaviors as well. Often with young people with ARFID, we might see them eating really dense foods like French fries or chicken strips, as you see in the picture, and that might be the only foods that they eat. And so kind of watching for what types of foods. Is this restriction driven by a desire to become more healthy, or is this maybe driven by the colors or the texture or other reasons for those types of foods? And these would be really helpful things to highlight when you connect with a primary care practitioner. And something also to be aware of is that sometimes we see shifts in diagnoses as well. So we know from a group of individuals who were seen in Ontario for a research study by a colleague, Dr. Mark Norris, just under 10% of them initially were diagnosed with ARFID and then were later diagnosed with another eating disorder, anorexia nervosa. So it's something to be aware of in terms of watching. Maybe you didn't notice body image concerns at first, and maybe that changes over time. And so it can be helpful to check in and be aware of what you're noticing in your child's behavior and sharing any changes in that to help guide what types of eating disorders that might be associated with. So now I'd like to launch into some of the ideas about what caregivers can do in terms of making changes to eating routines. Because we really believe that when you understand what might be driving some of your child's ARFID symptoms, or what their fears may be, that can help caregivers make changes to those routines at home to help support their child and also help make those gradual changes as well. And when we think about ARFID, as we highlighted in the beginning, ARFID doesn't look the same for every individual. In fact, as we learn more from research about ARFID, what we're seeing is that there's 3 types of thoughts and behaviors that fit with ARFID, and that somebody might have only one of those, or somebody might have 2 or all 3 of these. And so the three types of, I'll call them dimensions or areas of ARFID, are fear of consequences. So somebody might restrict their food because they're really worried about what might happen. I'm worried if I eat, I might choke, I might throw up, I might have a lot of pain. And so I'm restricting my food so that I don't need to have that really scary thing happen. A second part of those behaviors is sensory sensitivity. So this would be a young person who restricts certain types of foods because of their texture or other qualities, sensory qualities of the food. And then the third is kind of a lack of interest in eating. So young people might describe, I don't really have an interest in food, or I'm not hungry. And we can see that sometimes that one overlaps with other ones as well. And so when we're talking about ARFID and strategies, we'll be thinking about what strategies might fit depending on which types of ARFID symptoms you're noticing with your child.
Now we're going to walk through a cognitive behavioral model of ARFID, and you'll hear a little bit later on about cognitive behavioral treatment for ARFID. But this is sort of some of the building blocks of how we understand what might be going on for young people who have ARFID symptoms. So a biological predisposition, that's something that you're born with that might impact the way that you experience food or sensations or fears. That's kind of one of the sort of building blocks that we see as being important for understanding why young people may develop ARFID, or food-related trauma. So Jennifer was just mentioning that a young person might be fearful of vomiting or choking, and often this fear develops after a very real and very scary experience for a young person. They may have had even just one experience that was really negative related to choking or feeling sick after eating that may then set off a pattern of avoidance around food. And I really want to highlight this piece because we mentioned earlier, eating disorders are not a choice. And though it may look in the moment that a child is choosing not to eat, we don't get to choose our biology. We don't always get to choose our experiences or how they impact us or the way that our body responds to sensory experiences or fears. But then that biological predisposition or food-related trauma can lead to disgust about new foods or fear about new foods. And often this can turn into beliefs about whole categories of foods. So things like vegetables make me gag, so I'll hate any other veggies, even if I haven't tried them yet. And then when we have this disgust about new foods, that can lead to restricting or limiting the amount of that food that we're eating. That can be both restricting in terms of the variety of foods we're eating or the volume, the amount of foods that we're eating. And then the more that restriction is happening, the fewer opportunities that a child or young person has for exposure to a particular type of food or volume of food or variety of food. And it can also lead to nutritional compromise depending on which foods are feeling safe and which foods are not. This can also have some medical consequences for young people. And that limited opportunity for exposure is really important to consider because we know that the more that we avoid something, even if we're avoiding it for a very good reason, the scarier it becomes and the harder it is to move forward with trying something new. And it may even be that the original reason that we were avoiding something wasn't necessarily because it felt scary, but it can become scary the longer time passes before we encounter it again. And so this example here of a bridge, if you have a fear of heights or driving over a bridge, you may go the long way on your way to work to avoid driving over that bridge. And what can happen when you do that repeatedly is you can start to believe, oh, the only reason that I've been safe is because I haven't had to cross that bridge. And if I did have to cross that bridge, I don't think I could handle it or something really bad could happen. You never get the opportunity to see actually what would happen if you did cross the bridge. So, this can be applied to a lot of different fears or avoidance related to foods. And one thing that we want to highlight is that if there is an anxiety component for a young person who's dealing with ARFID, that's something that there's lots of different professionals who are well equipped to be able to support. And places like your local child and youth mental health can support with any anxiety that might be contributing to food restriction.
And so now we'd like to jump into some strategies for those two components of ARFID when a child maybe isn't interested, has kind of a lack of interest in food or eating, or has sensory sensitivities. And I'd really like to acknowledge a colleague through the feeding group who shared these strategies and whose group has provided supports for families with these presentations of ARFID. One of the things my colleagues highlighted is that sometimes families, before seeking care or as they're starting to seek care, end up where every mealtime is becoming a conflict, where there's meltdowns, there's tears, there's voices getting raised at the table. And if you're noticing this pattern happening, I think one of the things to be aware of is a tendency can be, okay, well, the food is leading to this conflict, so let's stop this battle. And then we don't want to inadvertently or by mistake lead to so much avoidance that then we see that pattern that Caitlin was just describing around the more we're not used to seeing something, the scarier that it can become. And so some of the strategies that may be helpful for families as they're trying to shift that pattern. If a young person is not ready to eat a food and you're not yet connected with care providers, but really thinking about how can we keep moving forward, thinking about, are there ways to integrate that food into your family's routine? So maybe not removing the food completely, but still having it on the table, particularly if there are other people in the family who are eating that food and they can eat that food at their dinner, and thinking about what are those ways to continue opportunities to have exposure, to see that food, to have it around. And then related to that, how can we create opportunities for some of these really positive opportunities for interactions with food? So it might be thinking about going grocery shopping, and if you're with your child, asking them to put some foods in the basket at the supermarket. Maybe they're not eating these foods, but they might be able to go grab those Brussels sprouts or broccoli or other foods that you'll be preparing for your family and potentially having on the table, but not necessarily serving at this point. There are ways to get creative around play, crafts, incorporating foods, being involved with food preparation and cooking. So finding ways across the lifespan, across, depending on your child's age, appropriate opportunities to be involved and to have some of those positive interactions. One of the things that my colleagues highlighted is that they may hear from families who are really worried and concerned about their child's nutrition and thinking about each meal and snack and what balance there is in it. And so a strategy can be to think about this over a period of several days or even a week. Not every single meal needs to have a certain balance. And so if you're noticing that there's a day that may have certain preferred foods that your child enjoys eating, and you're missing some other of the food groups here and there, if you're looking at it over a few days or a week and thinking, well, okay, maybe they had less of that food group on this day, but they did get it in on another day. And so that is something that is part of the process. Now, one thing to highlight, though, is if your child avoids one or more whole food groups completely, there are supports available. And in BC, one of the supports is dietitians who can be available through the 811. This can be a place to get started, to talk through ideas about, okay, if your child isn't eating a certain food group, what might be some of the strategies for incorporating foods that might be acceptable to your child, or ways that you could help think about how to get the nutrients that they need within their balanced meals. And then the other piece that we really want to highlight is earlier intervention is helpful. Sometimes families share with us that they've waited to reach out for help because they might hear from others, well, it's a phase and maybe your child will grow out of it. And I think one thing to emphasize is that if you're noticing there are really these concerns that fit on the screener that Caitlin shared that's available through the National Eating Disorder Information Center, if you're seeing some of those interference, the way that gets in the way of doing social things with friends or family, then it can be helpful to reach out to a primary care provider and connect in order to explore whether there's supports that can be helpful even at an earlier stage. And one of the really important things to be aware of is that sometimes caregivers might be worried about what is healthy for their child, especially in ARFID, thinking back to Adrian's case, a child with a preference for those brown foods, for example. What we want to look for is foods that are dense. And what I mean by that is foods that are going to provide lots of nutrition without needing to eat really large quantities of that food. And foods that might be eaten by other children can be really helpful so that if they're going to a party, it's these foods that they're likely to come across. So a great example of this type of food would be French fries. And I think what's really important to reflect on is that the health messages that we might hear about for the general population aren't always relevant for people with eating disorders. French fries might be something that people are trying to eat sometimes when they're not trying to gain weight. But when we have a young person who is having restrictive eating, who really needs this nutrition, particularly those who are underweight, we really want to look for these dense foods. And I'll be talking in a little while about approaches like cognitive behavioral therapy for ARFID. And one of the things that the people who develop that highlight is that for people who are underweight, it's important to eat preferred foods. And they say if your child's preferred foods are cookies, candy, and ice cream, it's actually okay to eat those every day to support weight gain if those are the types of foods that your child prefers and that can help support that weight gain, because the weight gain is one of the really important emergencies within this scenario.
I'm going to shift to talking a little bit about what happens when eating problems go together with other concerns like pain or other physical symptoms. And I'll be talking in this section both about symptoms that are associated with a known medical condition as well as physical symptoms in general. So we know that worries about the negative consequences of eating is often linked to different types of physical symptoms. And often this is abdominal pain, but it could also be things like difficulty swallowing or feeling like there's a lump in the throat, nausea, bloating, or vomiting. And we know it's especially common to have disruptions to eating in folks who have different types of GI disorders. And that's true for children as well as for adults. And this can be things like irritable bowel syndrome, inflammatory bowel disease, celiac disease, many different types of GI conditions. And what's really tricky in this situation is that often children or youth will start to avoid certain foods because they feel like they're associated with an increase in symptoms, or they're trying to prevent their symptoms from happening. So they might avoid certain food groups or specific foods, or they might even just try to avoid eating in general. And what's really tricky about that is that if you're not eating regularly or not eating enough, that can actually lead to more GI symptoms. There's different things that can happen within the GI system that can make it harder to manage symptoms. So things like constipation can be more likely if eating is restricted or disrupted. It can also change the transit time of food within the GI system, which can have symptoms associated with it. And it's also really, really challenging to make a clear association between symptoms and foods that might be causing those symptoms. And so often what happens is the restriction might start off with just a small number of foods, and it might grow and grow and grow because the symptoms are so unreliable and hard to link to specific foods. So what we suggest looking at when there's physical symptom concerns is managing any medical conditions. And often this requires a team approach. We often talk about considering mind, movement, and medicine. So for many physical symptoms, the best approach is to have a combination of support for mind-body strategies and mental health, a psychologist or counselor, movement, like with a physiotherapist, and then any needed medicines or prescriptions. But particularly for the movement piece, it's important to check in with your primary care provider if your child's not meeting their growth expectations, to make sure that whatever level of movement or exercise they're engaging in is safe. It is still important to know what foods to avoid. And I gave the example earlier of food allergies, but that's a really good situation where avoiding a food because you're allergic to it is not problematic. In fact, that's helpful. But knowing sort of where the boundaries are of that and making sure that food restriction isn't extending beyond what's medically necessary. We talked a little bit before about that avoidance cycle, and really the way to break that avoidance cycle is through exposure. Often in the case of young people who are having physical symptoms, we talk about using mechanical eating, which is eating by the clock and not by the symptom. So not waiting for your symptoms to feel, perfectly comfortable or resolve completely before you start eating, because actually delaying and waiting until you're feeling better to eat can actually lead to more symptoms. It's important to develop coping strategies to reduce and manage symptoms, and I'm going to give some resources on the next slide to talk about that. But just as important as managing symptoms is also focusing on improving function, what matters for the young person, and how can we focus not just on the impact of the symptoms, but what do you want to be doing in your day that matters to you? And getting support for any other areas if your family needs them. So often young people who are managing both eating concerns and physical health concerns might need support around school, sleep, or mental health. And these are just a few resources to help with physical symptoms. There's a lot of really good research to say that different types of relaxation exercises are helpful for managing GI symptoms. And there's two websites here, Imagine Action and Comfortability, that have recordings and scripts for different types of exercises that are meant for children and youth. And also some really great resources on managing GI conditions and symptoms in general at GI Kids. Now, I want to talk a little bit about a study that we did recently where we were looking at families' experiences. These were families who had kids between the ages of 8 and 14, where there was a diagnosis of ARFID and or a GI-related somatic symptom disorder, who received care at BC Children's. And we asked families to share with us a timeline of key events around, how they got their diagnosis and how they were understanding and coping with their child's ARFID symptoms. And the three common themes that we found in families' care journeys, the first was drifting aimlessly. So this was a lot of uncertainty that families were talking about, both in diagnosis and treatment. And families talked about feeling frustrated because they felt like their concerns weren't being taken seriously or they were being dismissed. And also feeling like there wasn't enough expertise in their community or within their providers to know how to support a young person with ARFID. The second theme was the emotional impact on families. And I really want to acknowledge that, this is really, really hard. It's really challenging as a family member to be supporting your child with restrictions in their eating and also trying to navigate the care system and advocate for what your child needs. And a lot of families talked about how one of the hardest parts of that was feeling helpless or feeling lonely. And then finally, sort of related to this is the systemic barriers that families were encountering in accessing and being able to put a treatment plan in place. And again, many families talking about how they didn't feel like there were enough resources or that the treatments that they were being offered wasn't being tailored to their child's needs. So we took what we learned from those family care journeys into some recommendations of, how can we learn from this and how can we move forward and support families and support our healthcare system in providing better care. And we talked about the importance of identifying a pathway and regular medical monitoring, providing support for families, making sure that resources are available and peer support from other families who've been through this as well, and trying to reduce barriers by connecting team members with each other, since a lot of families said what was really hard was having to be the person going between all the different team members. And often when you're supporting a young person with ARFID, there may be a lot of different team members that are playing important roles in your child's care. There might be a medical team, an occupational therapist, dietitian, counselor, psychologist, social worker, nurse. And you can have a look at the College of Health and Care Professionals to see if there's a team member that you might be interested in working with who's part of a registered health profession, because everybody's situation is different, but often it helps to have a team that can look at all of these different aspects of care.
So at this point, we'd like to jump into some of the options that are available for treatment or support for ARFID. And one thing that we want to highlight is that there's different availability of access to ARFID resources depending on where somebody lives and how old your child is and what options are available within a certain region or program. At the end of today, during the Q&A, we'll be sharing some resources outside of these regional eating disorders programs, including some online resources as well as families are navigating, and also some resources about what types of questions can be helpful if you're thinking about connecting with somebody and you're not sure how much experience they have with ARFID. And one of the options that you can ask about, and that has some evidence for effectiveness, is an approach called cognitive behavioral therapy for ARFID, or CBT ARFID. And this approach is appropriate for individuals ages 10 and up. And we're starting to see more evidence for this treatment, that of the people who have had CBT ARFID, that it felt like it was a good fit for them, that we saw some changes, that people felt satisfied, and that their symptoms improved after engaging in this. And depending on somebody's age and how much weight they may have to gain, there are two different approaches. One can be just working with an individual on their own, and one might be for younger individuals or individuals who are still living at home and have weight gain as a goal, to have a family-supported approach. And this is an outpatient approach. That means you don't need to stay in hospital. It starts with understanding more about ARFID, education, having some early change, making a plan specific to you, and then thinking about what are those things that keep the ARFID going and how can we stop the ARFID from coming back. And this approach might not be such a good fit if there are certain concerns, like somebody is having safety concerns, active suicidality, having substance use, or who are really dependent on tube feeding or other types of supports. And then it would be really important to talk to your primary care provider to understand what supports might be available for those situations. And there's a workbook available on the Kelty website, and we'll just put that link in the chat as well, which is really intended for families who are connecting with somebody who will be able to provide cognitive behavioral therapy for ARFID. And there's some really helpful information there about understanding more about what is ARFID, the different types of ARFID, and some of those information that I shared about if somebody is underweight, what do we need to do? What are some of the next steps? Why are people saying that it's okay to eat ice cream and cookies as one of the steps for ARFID recovery? And then a second approach that also has evidence is family-based treatment for ARFID. And this is really similar to other types of family-based treatment, or FBT, such as for anorexia nervosa and bulimia nervosa. The approach really comes together to help support caregivers to really support their child's recovery and to make decisions about changes to eating with the goal to increase variety, while also highlighting the goal isn't to make somebody a foodie who has had a long-standing restrictive eating, but to increase their variety at a point that then it won't have so much interference on their day-to-day life, or where they won't be stuck having nutritional concerns or weight-related concerns. And just like CBT ARFID, there's emerging evidence that this is an approach that works and that families are satisfied with, and that actually it works by helping parents and caregivers become more confident with supporting their child's recovery. And there may be some of you here today whose child is no longer a little one, where they are already an adult and you're thinking about how to support them. Or sometimes as families navigate their child's restrictive eating, they realize that maybe they have their own patterns of restricted eating. And so the good news is that there's a book that was published by the same people who made that CBT ARFID manual that's really aimed at adults who may be experiencing symptoms of ARFID. And we have a link in the chat because this book and other books relating to eating disorders can be borrowed at no cost for those who live in BC or the Yukon.
And finally, just sharing one additional resource. It's a handout for families and supporting children and youth with restrictive eating. And the link for that is in the chat, or you can scan that QR code.
And so on that note, I will pass over to Nisha, who will be reading out some of the questions that have been coming in.
Yeah, thank you so much, Dr. Coelho and Dr. Borner. You've shared so many helpful insights and strategies about ARFID symptoms. And I know at the Kelty Center, we get so many questions about ARFID, and I know that a lot of parents and caregivers are worried about their child's eating and have a lot of questions. So it's really great that we are able to share this information today. So with that, let's start our Q&A portion. With just under 15 minutes left, we will be prioritizing questions that we've received in advance. So I will start reading out some of the questions we have received. So first question, are there occupational therapists in Vancouver that work with children with ARFID? Can I get a list with their contact info so I can get help for my child? Are there other specialists that can help my child? I don't know where to look or how to find them. Is there a way to know if the person is qualified?
Thanks for that question, Nisha. And I've also seen in the Q&A similar questions about other areas across the province about potential supports that are available. And so what we can share is that there are a few resources that people can look through. One is through the National Eating Disorder Information Center, or NEDIC. There's a Find a Provider resource, and you can then click on that and enter what are you looking for in terms of the type of eating disorder. ARFID is one of the options. Where are you located? Do you want to think about virtual services or in-person services? And so that's an option to understand for your local area. In terms of how to know if somebody is qualified, as Caitlin highlighted, some clinicians would be registered as part of a College of Health and Care Professionals of BC. This covers many health professions, including psychologists. I will note, though, that not all professions are part of this college. So there are some health professionals who may have a lot of experience and who aren't yet part of this College of Health Professionals, such as registered clinical counselors. And so it may be helpful to think about questions that you can ask a provider in order to understand what experience that somebody may have. And I'm aware of a website called the ARFID Collaborative that shares resources for ARFID, including online support groups and other resources, as well as a list of questions that you can consider asking clinicians who you're meeting with to understand their experiences for clinical care with ARFID. And so I think that we're just putting those links in the chat right now.
Thanks, Dr. Coelho. Another part of this question is, what do I do if my child says she doesn't want help and food scares her?
What I can share is that we hear this from families across eating disorder diagnoses. And I think the really important thing to keep in mind is that there are actions that you can take as a caregiver that can be really helpful to support changes to your child's eating. And this isn't specific to eating disorders. We see this across different types of worries. Kids who are worried and anxious about various things may have a really hard time thinking about going to connect with somebody to talk about it or to take actions on their own. And there's more and more evidence that for eating disorders and anxiety, that supporting parents to make changes to some of the things they may have been doing that maybe at first kind of helped. We call it accommodation, in order to try to keep the peace at home, in order to try to support your child, but which over time may end up leading to those worries building. And so what I would say is don't hesitate, don't wait for your child to say that they're ready, and that there are steps that you can do to connect with cares and supports, and some approaches like family-based treatment that are focused more on the actions that caregivers can take.
Thank you, Dr. Coelho. The next question is, we try to alternate for dinner with cooking something on the limited food list my teen will eat and cooking something for the whole family that we force him to eat or eat part of. He still doesn't take in enough calories. Is this a good strategy?
What I'm hearing with this question is a caregiver who's really aware of not wanting to totally take away some of those new foods to keep that exposure going, and trying to balance how much your child's eating with how much you're supporting those preferred foods, especially for a young person who's growing and who needs more calories. And I'll just highlight in the handbook that the link that's just gone into the chat, there's page 13 that touches on what to do, why do we need to prioritize weight gain for somebody who's overweight. And I think, while I can't comment on strategy for any specific family, what I can share is that making sure that there's enough intake while also trying to balance those opportunities for exposure, whether it's having it at the table or finding ways to be incorporating that. And that can be really hard to do without supports. I'd also highlight that the goal isn't to cause fights and conflict. And so I'm hearing the word force and also thinking, like, is there a way that we can continue to encourage those positive interactions? And if it's turning into those fights, that would also be a reason to seek out supports and understand what are those options to change that tone so that family meals can become more positive again, and a time for the family to connect.
Thank you, Dr. Coelho. The next question is, do you have any suggestions for situations in which there are multiple caregivers, not all of whom are on board with following these recommendations? Can effective progress be made when these guidelines are followed in some of the child's environments, but not all?
I'll take that first part of the question. And what I can share is that the research on FBT for ARFID is still ongoing. So we don't yet know enough about what conditions will this approach be more effective. But we know that across eating disorders, family-based approaches like family-based therapy, family-based treatment for anorexia, really focus on supporting caregivers to work towards consistency in their approach. And also recognizing that caregivers are juggling so many things, and there might be a lot of reasons why different approaches are taken across households. And so therapists who are trained in those family-based approaches could help a family navigate these kinds of situations. And depending on the age of a child, as I highlighted, there are approaches that are more individual focused, like CBT for ARFID. And so if it's a person who is older than 10, who is ready or willing to go to some appointments, that might be an approach with caregiver support that would look less about needing to have consistency across all households.
And there's another part to the question. Also, what about when physical symptoms such as constipation or reflux negatively affect the child's desire to eat?
So, I mean, I think that one of the most important things when there's a physical symptom is first make sure that you've got it evaluated by your primary care provider, and if needed, that any referrals to follow up on that are made. In the case of something like constipation and reflux, there are sort of medical treatment approaches that can be helpful in managing those symptoms. And so the first thing we want to do is just make sure that the symptoms are managed as well as possible. For constipation in particular, I definitely recommend that gikids.org website that I mentioned earlier. So once we've done all that we can kind of from the medical perspective to manage the symptoms, then some of it becomes about how do we cope with those symptoms and not have the presence of the symptoms cause increased stress, because we know the more your nervous system gets activated because you're feeling anxious about a symptom, the worse the symptom can actually feel. And this is definitely true for GI symptoms. And I'm thinking also about, you know, when young people feel like that lump in the throat feeling. That definitely gets a lot worse the more anxious you feel about it. So many of those sort of relaxation strategies can be really helpful. And again, this can be where it can be great to get some support from a mental health provider who's familiar with working with physical symptoms. Many child and adolescent psychologists have training in this area and could be a great source of support.
Thank you, Dr. Borner. Another question is, we saw a pediatrician a few years ago for help with this. Concerns were dismissed, and I felt patronized when I was told that my child was growing fine and was the picture of health because he was not obese. Our family dentist has also never heard of ARFID. What is being done to educate healthcare professionals in BC?
Thanks for that question. And I really want to acknowledge, just as Caitlin did earlier in the presentation, how challenging we're hearing this journey is from families across the province. And this is what we heard in our interviews with families as well, the frustration, the delays in connecting with appropriate services, and then that experience of trying to find that pathway and then not being able to connect with health professionals who really have an understanding of how to support children with ARFID being a common experience. And part of the role of the eating disorders program here at BC Children's Hospital is to provide consultation, education, and support to community care providers. And many of our team members have been involved in educational initiatives to share information about ARFID with professionals across the province. This includes work that Dr. Caitlin Berner and I have done for clinicians through psychology rounds at the hospital. We have pediatricians and other medical professionals who have been connecting with various groups. And I think part of what's been really hard is that until fairly recently, just a few years ago, there wasn't evidence about what are effective treatments for ARFID. And we had surveyed clinicians across British Columbia who had said that they don't feel confident in providing care for ARFID. And now that there's more research emerging on what are those treatments, when can we use something like CBT for ARFID, when is it more effective, I have the impression that this is changing with some easier access to trainings for health professionals, while recognizing that navigating the system isn't easy. And as Nisha highlighted, this is part of the role that Kelty can provide in terms of being a place to connect with peers and offering some service navigation that may be able to help the journey, as well as the links that we've put in the chat for the ARFID collaborative that highlight places outside of BC that have some supports.
Thank you so much, Dr. Coelho. And with just a minute left, I'd like to wrap things up. Thank you very much for everyone who submitted questions today. We've received about 30 questions, so I'm sorry that we didn't have time to go through all of them. And a very, very sincere thank you to Dr. Coelho and Dr. Borner for being here today and connecting with our webinar participants. Thank you also for our webinar participants who made the time to join today. Please contact us if you have any other questions that didn't get answered. Both our email and phone number will allow you to connect with our family peer support workers. And also a reminder that if you are a parent or caregiver of a child aged 4 years or older with symptoms related to ARFID, you are invited to participate in a short online study, and the link for that is in the chat. Please follow us on social media or sign up for our newsletter to stay up to date on our latest resources. And if you have time, please remember to fill out our feedback survey that will pop up after the webinar closes. It's also in the chat. We really appreciate any feedback you have. And lastly, a recording of this webinar will be uploaded to the Kelty website, and it will also be emailed to you once it's available. Thank you so much, everyone, for joining, and I hope you have a wonderful rest of your day.